Hi, everyone. I'm delighted to be here and to be part of this panel discussing fertility preservation legislation that we've been working on and the importance of it. So I'm going to let the panelists each introduce themselves. We're going to try to keep our comments brief, about 5 minutes each, because we'd like to generate discussion and answer any questions that you all may have. So Teresa just introduced me. I am a bioethicist. I'm at Albany Medical College. I had the privilege of working with Teresa for 2 years here as a postdoctoral fellow. I'll just go ahead and get started. So the question, I'm the only non-lawyer on the group here, so I'm going to sort of introduce the theoretical framework here and then leave it up to the lawyers to get to the nitty-gritty. The question I'm interested in is, should insurance companies cover fertility preservation technology, FPT, for cancer patients? And the way I'm going to answer this question is by doing a comparison. And so philosophers like to make comparisons, especially when they're talking about distributive justice, right? We want to treat things either the same in order to be fair. So we want to treat men and women the same in certain ways in order for fairness. We want them both to be able to apply for the same sorts of jobs, that sort of stuff. So I'm going to compare fertility preservation technology to breast reconstructive surgery after mastectomy. And I think these are similar in a few important ways. They are both iatrogenic, treatment-induced conditions that are often conceived of as not really medical conditions when they're naturally occurring. So I'm going to explain this a little more in the next slide, but I just wanted to give you the overview here of what I'm talking about. Okay, so here's this beautiful chart we have here. I'm going to start at the top slide here. If someone is born naturally with asymmetrical breasts, or in a rare case, I've never heard of such a case, but with only one breast, insurance companies will generally not cover that. They see that as just a natural flaw that a woman may have. And in some cases, breast asymmetry can be quite dramatic, can be quite a huge difference. But insurance companies generally see that as something that's not a medical condition. They won't cover it. However, they will cover breast asymmetry or breast absence when it's iatrogenic. And I'm going to explain in just a second why they do cover that. That's federal law. They have to do that. Infertility, when it's naturally occurring, is sometimes covered by insurance companies. There are now, I hope I have the number right, 15 states that mandate that insurance companies cover infertility treatment. But there are all sorts of caveats and whatnot. But often, infertility is seen as a social problem. It's not really seen as a medical disease. It's seen as producing a social desire that is biological parenthood and not really a medical condition. That seems to be changing, so that's good. But often it's seen as just, that's not really medical issues here. So it's often not covered. When it's iatrogenic, it's usually not covered either. It sometimes is if you can fight for it and you can appeal, as we've been doing here at the Fertility Consortium. If it's coded under cancer treatment rather than infertility, it can be covered, but not always, and it's a lot more difficult to do this. Okay, so why is iatrogenic breast reconstructive surgery covered? Well, it's due to WICRA, the Women's Health and Cancer Rights Act, and this was in 1998. And as you are probably aware, in the 1990s, there was a lot of breast cancer activism, pushing for all sorts of more funding and all sorts of other things, and this resulted from that. And this mandates that if health insurance companies will cover the cost of mastectomy, they must also cover the cost of reconstruction. And not only on the breast that the surgery was performed, but also on the other breast to produce symmetrical results. And there's no requirement saying that if you were a cup B beforehand that you have to be size B afterwards. You can go to triple D if you want afterwards. There's no ruling about that. But there is the idea that you have to be returned to your prior state and have two breasts that are symmetrical, even if your breasts were not symmetrical beforehand, okay? Part of the reason why this is covered is it's coded as cancer treatment. It's not coded as cosmetic surgery, and that's the difference there. So I want to compare these two and say that they are similar in important ways that make it unfair to cover one and not the other. And the two similarities I'm going to discuss here are, first, patients' motivation for treatment. Well, the first one is it normalizes women's body. And as I just discussed, often in medicine there's this idea of returning the body to the pre-disease state. So if you remove someone's breast, according to the principle of non-maleficence, to do no harm, you have to return the body back to its prior state. So if you remove someone's fertility, you have to bring it back. If you remove someone's breast, you have to give it back, right? This idea that the body is somewhat static and you have to return it to its pre-disease state. Also, there's the idea that we have to repair women's gendered identity. Women's breasts and women's fertility are very important to many women and to society at large. These are gender markers. This is what we associate with women. Breasts, fertility, those are signs of women. And this is why I think this is partly covered, the WICRA Act, is because it's really important for us as society to know people's gender. And that's why the Saturday Night Live skit of It's Pat is so funny, is because we don't know Pat's gender, right? We don't know how to act around Pat because Pat, we don't know if Pat's a man or a woman. We need to have these gender markers. We need breasts, we need pregnancy, we need long hair and skirts and all these things. So that, I think, really plays an important role, even though we may say, well, someone can live without a breast, right? You don't need a breast to survive, but it's important to people's identity and to society as a whole here. The other comparison is safety and success. So both of these are FPT is becoming more and more successful. Certain treatments are still considered experimental, but that's changing. There have been problems with safety of breast implants, and from 1992 to 2005, the FDA banned silicone breast implants because of safety concerns. However, they allowed them only for people who had mastectomies, and the reason was it was more devastating to not have a breast, so it justified the health concerns, because not having a breast was worse than the health concerns, which I think is really interesting and telling about this idea of how important gender markers are to us as a society. The main difference I see here is the timing of treatment. Breast reconstructive surgery happens after cancer treatment. You don't have a breast, now we're going to replace it, whereas FPT happens beforehand. And so this may seem like an important difference, but we do a lot of prophylactic treatment. And insurance covers that. For example, if I'm going to have surgery, they may prophylactically store my blood in case of an emergency transfusion. To prepare for the worst case scenario, we may cover these prophylactic treatments. Same thing with FPT. In the worst case scenario, I become infertile after my treatment, we have this backup plan that we can resort to, my frozen embryos, say. Okay, so I think that difference is not as important as it may seem at first blush. So if we agree that these are similar and not different in important ethical ways, then I think as a matter of fairness, they should both be covered because they're so similar. And if we agree that they should be covered, then what should we do? Well, that's where I'm going to turn it over to Monica, who's telling how we apply this theory into practice. Thank you.
Well, thanks, Lisa. I think you teed up the issue really, really well. While we're getting the slides set up, my name is Monica Bryant. I work for a nonprofit organization called the Cancer Legal Resource Center. And very briefly, to give you some context as to why we're involved in this issue, we are a nonprofit whose mission it is to provide free legal and financial information to anybody that's coping with cancer. So oftentimes that legal information has to deal with insurance companies and insurance coverage. A little bit of background on me is before I came to the CLRC, I worked in Congress both on the Senate side and on the House side first as a law clerk and then as a legislative counsel. So my background is drafting pieces of legislation to try to sort of make things better for people. And now, in this case, make things better for people who are coping with a cancer diagnosis. The first sort of step that has been taken is a bill that was introduced in the California Assembly called AB 428. And it was sponsored by Assembly member Anthony Portantino, who is a Democrat from sort of the Pasadena area, so Southern California. It was introduced this past February. And for very many political reasons that I don't have time to get into today, it was introduced really quickly, and it was pushed to committee really quickly. And the idea was that in California, it's a Democratic legislature at the moment, and people felt that they might be more favorable to this new concept of covering fertility preservation treatment. So there's been discussions about covering infertility treatments for many, many years at this point, but this is sort of a new concept in the minds of legislators. So on May 3rd, it actually went to the Health Committee and was passed out of the committee a vote 13-6. It is unsurprising that that vote was completely down the middle on partisan lines. 13 Democrats voted yes, 6 Republicans voted no. Many of the arguments were heard that this kind of bill was going to cost insurance companies an astronomical amount of money. LiveStrong has done quite a bit of work to show that that is not in fact true. I believe it's 3 cents a insured individual that this is about what this is going to cost. 3 cents. It's nothing. We thought that this was a good thing, that the bill got passed through the committee so easily, but unfortunately in California, any bill that is going to have a potential fiscal impact on the state automatically gets referred to the Appropriations Subcommittee. It's stuck in the committee, and it probably won't come up again until next year, if at all. So what does the bill actually say? I know many of you probably can't see it, but this is the entire bill. It's 3 paragraphs. Essentially what happens is this bill applies to group or individual plans that are issued after January 1st, 2012. That date will obviously have to be amended since the bill won't pass before then, if it does at all. And what it does is it requires insurance companies to cover medically necessary expenses for standard fertility preservation services when iatric infertility may occur. So the first argument we heard about this bill was, you're forcing insurance companies to cover infertility treatment. That is not what this bill says. The actual language says only fertility preservation treatment, so that's beforehand, which makes tons of sense to all of you in this room, but explain it to a legislator who has no idea what we're talking about. So in theory and in concept, it's a wonderful bill. However, this is why they bring the lawyers into the room, there are some significant problems that we as the CLRC see. So first, the fact that the bill says that insurance companies are only required to cover the medically necessary expenses with respect to fertility preservation treatment. Well, that is an insurance company's dream. It is completely ambiguous language, it's not defined, and what's medically necessary? So are we just covering the removal of the sperm? Are we just covering the anesthetic that might be necessary? Are we just covering the doctor's time? What's medically necessary? The other issue is that this bill doesn't address the issue of an absence of a diagnosis of infertility. So many insurance companies were hearing through the grapevine that they're saying, well, we'll cover this if there's a diagnosis of infertility. Well, when we're talking, as you all know I'm sort of preaching to the choir here, but as we're talking about, that's a major issue with this piece of legislation. This bill also doesn't address how insurance companies deal with co-pays, deductibles, and co-insurance. So yes, we may say insurance companies have to cover fertility preservation treatment, but then insurance companies can say, okay, fine, but there's going to be a $1,000 copay, $10,000 copay. We won't accept co-insurance for this. Or you'll have to meet your entire deductible. And some people have very large deductibles. Another issue is that this bill doesn't address if fertility preservation treatment would be subject to lifetime and annual limits. I believe we're going to hear a little bit more about the Affordable Care Act or healthcare reform momentarily. One of the things healthcare reform did is it said that insurance companies can no longer impose lifetime limits, but they can that restriction only applies when a lifetime limit to an essential health benefit. Well, is fertility preservation treatment going to be considered an essential health benefit? And we still don't know. HHS still hasn't put out their regulations of exactly what's going to be considered an essential health benefit, so we don't know. But chances are, unless we do some advocacy, it's probably not going to be considered that. This bill also doesn't do anything to define what's considered standard fertility preservation treatment. So is it what's standard right now? Is it what's standard in 3 years, 5 years, and 15 years? And that leads us to a legislative issue and a legal issue of what happens as the science advances. We're going to be stuck with an archaic law and case law that doesn't keep up with the science. So in conjunction with LiveStrong and their sort of fertility branch, Fertile Hope, the CLRC has put out a position statement about exactly what we think needs to be included in any piece of legislation that deals with insurance coverage for fertility preservation treatment. I know the link is horrendous, but there's the link for you. I think Lisa and Teresa could probably send it around if folks are interested in it. But it basically it says that any piece of legislation has to address all of those issues I just talked about. Okay, so what are our next steps? What can we do about it? Possibly advocate. If you live in California, this might be something that we need to be talking to legislators about. And are we advocating for maybe amendment of the bill or simple passage? Some people believe that let's just pass this bill, even if it isn't perfect, because at least it gets something on the books and it's a step in the right direction. Some people think, what's the point unless it's a really good bill and really protects people who are coping with cancer? Maybe there needs to be more research. Maybe the research that's been done that says it only costs 3 cents a person isn't strong enough, isn't compelling enough for insurance companies to be forced to do this. Possibly, let's try a bill in another state. Maybe that's an issue. Maybe we've talked a lot about this, is that maybe the solution is to do a sort of state-by-state procedure to start including these laws in various legislators. Perhaps it's federal legislation. The CLRC has drafted initial legislation, but as most of you probably know, the political climate for any other type of insurance mandate at the moment is not ideal, especially when we're in the process of fighting for to keep a lot of the provisions that the ACA implemented that do help people coping with cancer. So I think this is one of those situations where there's still a lot left to be done, and there's still a lot of disagreement within the community about how exactly to go about doing this. And maybe it's not just that we take one approach. Maybe it's that we really try to attack this from multiple avenues. So there you have it. And with that, I'm going to pass it on.
Faculty member at the University of Baltimore and also co-director of a Center for Medicine and Law there that we run jointly with Johns Hopkins School of Medicine. And when I was asked to come back here to the Oncofertility Symposium, I was certainly very grateful, but both initially and after sort of having spent a day and a half here, a bit embarrassed because as a lawyer, sitting here and listening to the wonderful advances in science that have been made in 5 years, I have pretty much nothing even close in comparison to say that in the legal world we've made similar advances. Pretty much I came here with the idea to say, well, not much has changed since the last time I spoke. But that's both not unexpected, and perhaps in some ways a good thing. The law is slow and it is usually reactive. Judges and legislatures generally don't think in terms of what should we do to anticipate something that may happen down the line. They usually see something that has already happened and then they react. Sometimes not the way we would like them to react, but they do nonetheless. Think about the experiment with Dolly. Cloning just was not on the radar screen of any legislator until Dolly was born. And then they started passing all sorts of laws. Again, not always to the benefit of the science. And that's what brings me to the point that perhaps the fact that not much has happened in the last 5 years is a good thing, because we are sort of at a very, pun unintended, we're still at the very embryonic stage of science here. And perhaps we don't want the legislators and the courts getting involved too quickly and with too of a heavy hand. And even then, the reaction, to the extent that it eventually will come, it is very slow. And if you don't believe me, look at the big bill that was just recently passed, the Patent Reform Act of 2011. It is not a topic that gets almost anybody's blood boiling, and yet it still took about a decade to get that hashed out. So you can imagine how long it usually will take to address issues like insurance coverage for fertility preservation. So with all of those caveats out front, I still want to talk about some of the legal changes that have happened that are not directly relevant necessarily to the field of oncofertility, but that may eventually impact it as we go forward. And the first one, as was referenced in the previous talk, is the Patient Protection Affordable Care Act. And the PPACA may certainly influence the legal landscape for oncofertility. And I'll just highlight a couple of salient features of PPACA that may be of relevance. First, there is a ban on pre-existing medical conditions. And again, so I want to just preface it by saying that a lot of it will depend on how the rules that implement this act will be written. But one can foresee that the bans on pre-existing medical conditions may be used to limit insurance exclusions for not truly infertile couples. If insurance says, well, you're not really infertile because by the time, before you start your cancer treatment, you, in theory, can't get pregnant. So at this point, when you're seeking protection, you're really not infertile. So we are not going to cover it, which is pretty much what is happening now. And perhaps if rules are creatively written, the ban on pre-existing medical conditions can be used to limit such an approach. The other feature of PPACA is the requirement for insurance coverage of preventative care. And again, depending on how rules are written, if the regulators can be convinced that fertility preservation for women who are about to go into cancer treatment, perhaps that can be covered under preventative care, much like Lisa suggested that we store blood before major surgeries. There's currently regulations in the works that generally pay more attention than usually has been paid to female reproductive technology and female reproductive health. For example, there's at least proposed rules requiring insurance to cover without a copay over-the-counter contraception coverage, so the pill. And again, properly and creatively interpreted, that ultimately that may lead to coverage not just of treatment that prevent pregnancy, but perhaps also for treatment that will permit women who wish to get pregnant to do so. Elimination of caps has been mentioned, but again, it will depend on how the rules are written, what those caps will be applied to or not applied to, and a lot of it was sort of in a wait-and-see posture, both in terms of how rules will be written, in terms of how different waivers will be implemented, because the bill does allow the Secretary of Health and Human Services to grant waivers to individual states and other jurisdictions to design their own healthcare plans. And then, of course, we're also waiting on whether or not this bill will even survive Supreme Court review. As many of you know, right now there's a split between two appellate courts. The Sixth Circuit, which covers a number of Midwestern states, upheld the act in a 2-to-1 decision. The 11th Circuit, that covers a number of southeastern states, also in a 2-to-1 decision, struck down at least part of the act, and probably the only way to resolve it will be in a Supreme Court. And that should, if it happens, probably will happen in the next year or two. So we're still a bit in a holding pattern. The other point that I wanted to make is that there are, in addition to these legal changes, there are societal changes that are oftentimes expressed in legislation. One thing that caught my eye recently was the proposed, and ultimately not voted on and not enacted, but San Francisco ballot initiative that would have banned circumcision. And one would think, well, what exactly does that have to do with oncofertility? And the point, I think, is that societal perception of what is acceptable and what is not acceptable changes. And although most of American population believes circumcision and parental consent for circumcision is legitimate and appropriate, that is no longer as given as it was just 15, 20 years ago. So we should be aware that what society believes is proper and improper, especially when it comes to parental consent for children's health care, does change and does get affected by news media coverage and generally people's changing views of the role of children and the independence of children in society. So although, again, circumcision battle in San Francisco does not directly reflect on oncofertility, it is indicative of the potential changes that we'll have to monitor if we are to succeed in pushing our legislative agenda. And what I want to close with is that there's a great importance of communication between the scientists and those individuals who ultimately will lobby and write legislation. Lawyers, by and large, are not scientists. In fact, as I joked with a number of you yesterday, most lawyers went to law school because they couldn't do math and science, and they don't understand it. And oftentimes, like I said, they're reactive, and sometimes they react in a way that scares me, and so I'm not going to do that, whatever that is, without understanding what that actually is. So they need to be educated, and they need to be educated in layman's language as to what it is that we are trying to accomplish. They don't particularly react very well to complicated scientific terms just because they don't get them. That's true about legislators. It's true about judges. At some point, somewhere, a judge will be forced to decide whether or not to side with one parent or another when parents disagree as to whether or not to subject their cancer-stricken daughter to surgery to preserve her fertility. At some point, a father will come down on one side, a mother will come down on the other side, and a judge will have to resolve it. And if the judge doesn't understand what is going on, he'll still render a decision, but it may not be a decision either in the outcome or in the reasoning that is appropriate or the one that we would want. So the point is that you as scientists have to keep communicating with those of us in the legal profession and do so in a layman's language so that people who do ultimately write legislations and judicial opinions understand. And the Fertility Consortium has been really good at it with an iPhone app, with a website that is accessible to non-scientists and non-physicians. But that is not an area where we can rest on our laurels. It is sort of an area where communication needs to be ongoing and needs to be done in a way that is accessible to pretty much everyone. So with that, I'll close and I'll turn it over to Dorothy.
Okay. Good morning. I'm Dorothy Roberts, and I'm a professor at the law school right down the street, and also faculty fellow at Institute for Policy Research. And I've been asked to talk about fertility preservation and questions of insurance in particular through the lens of gender, race, and justice. And this takes into account that fertility preservation and the legal questions we've been talking about and the scientific questions and ethical questions we've been talking about operate in a social, economic, and political context. Gender, class, and race inequality shape reproduction, reproductive health policy and laws generally, and also assisted reproductive technologies in particular. And so the ethical questions that have come up don't just operate at the bedside or in the clinic. They also affect broader social questions, and broader social forces affect the choices that individual patients and doctors make about fertility preservation. And especially when we get into devoting public resources to fertility preservation decisions of individual women, we have to take into account the social context even more. And so, as Teresa said yesterday, these are public interest as well as personal interest questions. And what I find really fascinating about these questions is that they bring up paradoxical questions and tensions that policymakers and legislators and all of us, I think, have to consider. And I think on some of these, I won't be preaching to the choir at all. I think some of you might be upset about some of what I say. But I think these are really difficult questions that we need to think about as we ask, what is our legislative agenda? So beginning with gender, do policies that support fertility preservation equalize fertility, or do they reinforce repronormativity, a term I'm borrowing from a legal scholar, Catherine Franke? As Teresa started out yesterday, the mission of the Oncofertility Consortium has been, in a sense, to equalize the situation of men and women. Even though men and women had the same hope for survival, as she pointed out, women had far fewer options for fertility preservation. And so in a way, this simply puts men and women on equal footing. And so you could say this is a dramatic example of gender equity. On the other hand, many philosophers and feminists and other kinds of scholars have questioned whether or not the expectation that women will become mothers isn't something that we should challenge. So when Lisa talked about gender markers, being a mother, one of them, is that something we should accept, or should we challenge this expectation? And does public support of fertility preservation further the expectation? Is the reason why we almost take it for granted that a woman will want to preserve her fertility? Is that based on an unjust stigma of infertility and of childlessness? In a way, the decision not to have a child is treated in our society sometimes even more harshly than the tragedy of infertility, because it's seen as violating a gender norm and being very selfish. And when we're talking about girls, the pressure is even more, because girls whose fertility has been preserved through oncofertility procedures may experience all the effort and money that went into the procedures as additional pressure for them to use those eggs and become a mother. Also, some have criticized high-tech reproduction for perpetuating an exclusive notion of genetically based family. You, of course, can become a mother without having a child who's biologically related to you through adoption or collaborative reproduction. Does enhanced support for fertility preservation reinforce this notion? Of course, some members of the consortium are doing research on barriers to adoption that cancer survivors face. A response might be, well, then put more effort into removing those barriers to adoption. So I think attention in terms of gender, is this gender equity, or is this reinforcing unjust gender norms? Moving on to economic inequality, clearly expanding insurance coverage for oncofertility increases access, and it can be seen as a equalizing measure that is just, because it allows not only the extremely wealthy who could pay for this out of their own pockets, but more people to have access to these procedures. Or is it privileging people who are already advantaged? Why would it be privileging people who are already advantaged? Because those are the people who have access to private insurance, which is going to cover these procedures. Poor and low-income people may not even have private insurance. And so the effort to cover these procedures under private insurance won't help them. Medicaid does not generally cover fertility treatment. In fact, the public response to women receiving public assistance is, you shouldn't be having any children. Don't ask for, there's an outrage if you suggest that they should have access to fertility treatment. No, we have laws in this country that deny them benefits if they have an additional child in order to explicitly keep them from having more children. So is our legislative agenda really just, or is it on the side of people who are already privileged in our society? Then it gets even more complicated when we look at racial inequalities in this area. On the one hand, expanding insurance coverage again equalizes opportunity, because more people, regardless of race, will have access to the technologies. But does it reinforce racial assumptions and inequities that already exist? Clearly, we need to equalize better access to fertility preservation and all sorts of high-tech fertility assisting technologies. Not only are Black and Latina women more likely to be infertile, but they're less likely to use these technologies for a number of reasons, including financial, but also other sorts of barriers that they face. And one of the barriers, I think, is deeply held stereotypes about the maternal unfitness of Black and Latina women, and repressive policies that have existed in this country for centuries and continue to this day, aimed, as I just mentioned, deterring primarily women of color from having children, that have historically devalued their decisions to become mothers. In addition, the images of the progress and promise and successes of high-tech reproduction usually are of white babies. That's this image from a fertility clinic, very typical. This is labeled the success of the fertility clinic, images of lots of white babies, whereas usually when Black babies are mentioned in the context of high-tech reproduction, it's because there was a mistake, a horrible mistake where someone who didn't want a Black baby gets one, and including lawsuits claiming damages for having a Black child. So we know that from studies of the use of reproduction assisting technologies that African American women are more likely to use them when barriers have been removed. And I think this is a strong argument for removing those barriers. They want to use these technologies. As a study looking at the military health system found, Black women in that system were 4 times more likely to use these technologies than Black civilian women. But studies have also found that insurance coverage isn't enough. Racial disparities persist despite expanded insurance coverage of reproduction assisting technologies, and even in states with mandated coverage, the people who access these services tend to still be primarily Caucasian, highly educated, and wealthy. Why? Well, low-income women of color rely more on Medicaid. They're more likely to be uninsured, and they generally have lower quality health care. Carrie Snyder mentioned yesterday what she called startling results, that the African American women in her study were far less likely to even be told about fertility preservation. If they were, they had very superficial discussions with their doctors. And the Institute of Medicine, many other studies have found lower quality health care for African American women and Latino women. And improved access may not translate into improved outcomes, the actual birth of a live baby, even when, again, African American women use IVF, they have far lower rates of live birth than white women. So to conclude, what the big question, what is the just use of our resources? It could be argued that expanding the scope of insurance coverage, but not basic universal health care, to the most marginalized, vulnerable women who don't even have good basic health care, let alone high-tech procedures, that this just privileges affluent women who already have better access to care. Or we could, at least, I think we can all agree on this, or we should all agree, that we need to, along with improving access to fertility preservation, improve the living conditions and eliminate disparities in medical care. They have to go together to have a just distribution of medical resources in this country. Thank you.
I just wanted to let everyone attending know that LiveStrong is pursuing a strategy of working with private insurers to put this coverage in place. And we've been getting some success with that strategy, and I know we've worked with the CLRC very closely on, this as a precursor to legislation that then would give broader coverage. So we've had some success with that, and new companies, I just heard about someone yesterday, who are self-insured, large corporations who are starting to enact this coverage. So it is getting some traction.
Hi, I'm Marla Klayman from Northwestern. I wanted to, this is really for all the panelists, but I wanted to go back to this idea of state legislators. So I just did some quick research to clarify my numbers. So roughly a quarter of all state legislators do not have a college degree. And only about a quarter of state legislators are women. And I wanted to hear from the panelists as well as potentially others who are involved in things like onsen in terms of what it even means to try to discuss these types of topics with people where we know that at a general level, the general population and even educated populations don't really understand the types of technology, the speed at which the technology moves, and then the expectations of trying to put these things into law and also sort of sell them to the public. It's a little question.
Well, I guess it surprises me that only a quarter don't have a college degree. But I mean, it's not. I guess it goes back to what I was saying. You know, people who write legislation are usually not scientists, and even those who are scientists, they may be they know their area. You know, Rush Holt, Congressman from New Jersey, is in fact a nuclear physicist, but I would venture to say probably doesn't know much about oncofertility, despite being obviously very, very smart. So I think what oftentimes helps is really talking to them in a layman's language and using real people's stories. One of the reasons, for example, that end-stage renal failure is covered under Medicare, no matter your age, is precisely because the committee chairman who was writing legislation at the time had a relative with end-stage renal disease, and lo and behold, it made it into the bill because it was easy to talk to that person saying, okay, this affects you in this particular individualistic way. And that doesn't necessarily mean that you have to find every legislator who may have a daughter or a wife or a sister that may be stricken with cancer and want to have kids, but I think when you're talking to people without college degrees or even with college degrees who just don't know the science, you need to bring it down to the people's level and explain to them what it will cost. Is it really going to be 3 cents per patient, or is it going to be a ginormous expense? And explain to them and show them real people will affect. It's just very much retail politics. I don't think there's any other way.
Well, I will say personally, I do have a law degree, and 2 years ago, before Lisa and Teresa sat me down in a room, I had no idea what the word iatrogenic meant. But in about an hour, they were able to explain the issue to me. I mean, still some of the science, I'm like, this is way over my head, but there are ways to talk about the issue and to talk about things, and you don't necessarily have to understand every aspect of the science. I think the trick comes in very much like what Greg was saying, is that you have to frame the issue in a way that people are going to understand it. And it's not just about legislators. It's going to be about the general population as well. And how would you even explain it to a patient? So I think that has to start being the discussion. I think the Oncofertility Consortium is definitely headed down that path of saying we have to start explaining some of these very complex scientific ideas and frame the issue in a way that people are going to understand it. And that's certainly one of the challenges of passing legislation.
Hi, I'm Alice Creasy with Fertile Action. I was one that testified for that bill on behalf of patients and spent 3 weeks lobbying with legislators. I was much more interested in sitting down with Republicans and Democrats because we were pretty confident that Democrats were going to pass it. And I'm very, very passionate about this issue and about this topic. I did speak to Joanna Morales before we actually put this bill up for legislation and heard everything that she wanted in the bill. I spoke with Portantino about putting those things in the bill, and we have a strategy. And that strategy, we wanted this to be a 2-year bill. Portantino is a legislator, so of course he wanted to win this year. But a 2-year bill in the state of California that is completely and utterly broke is the right strategy to go about introducing any new piece of legislation right now that has a cost associated with it. And that I wanted to clarify a couple of things. That 3 cents is actually the max that it would cost, and that came from an independent auditing agency that the state of California uses any time a health bill has any kind of financial impact.
So they actually showed that it was between 0.14 cents to 3 cents. And we're working with them on following up with that analysis because we actually think we can get it to 0. Dr. Mitch Rosen out of the University of California, San Francisco, he published a paper. They did some research that actually showed that cancer patients are choosing less effective forms of treatment if they don't have access to fertility preservation. And that costs the healthcare system much more. So that's how we're showing that we can actually get this down to 0. So I just want to reassure CLRC, LiveStrong, Fertile Hope, that we actually are very much interested in closing those loopholes. And like Lori said last night, society's broken. And even in the breast cancer comparison, I don't have any expectation any piece of legislation is ever going to be perfect. And a piece of legislation is going to be perfect before we actually put it up for a vote. I was one of the people who fell into a loophole with the Breast Cancer Reconstruction Act 3.5 years ago when I had breast cancer, and my insurance refused to cover it. I know many women in the state of California whose insurance refuses to cover their breast reconstruction. These are young women. So there's loopholes everywhere. I was so honored by the opportunity to talk one-on-one with legislators. I was shocked by how many were willing to sit down with me and not give me their aid, and who gave me more than 15 minutes. I was thrilled with the opportunity to start a petition because the public doesn't know that age is the #1 impact on fertility, let alone that chemotherapy and radiation, let alone other drugs that can delay the window of childbearing years, impacts a woman's fertility. So I think that as a community, we should take every opportunity to leverage what's available. And I'm very proud of the state of California for being the first to introduce a bill, and also the first to introduce a bill that they're willing to continue working through now that it's a 2-year bill, and that I just wanted to assure everyone that that actually is part of the strategy. Thank you. Oh, and one more thing. Fertile Action works to eradicate costs for these women, and we have pro bono reproductive endocrinologists across 6 states. So, and we secure medications through Faring and some specialty pharmacies. So we're able to make sure that African American women, Latina women, and Caucasian women, all women, have access to these expensive treatments, because we do know that art is a luxury market and that the vast majority of Americans can't take advantage of it. Only, and in fact, actually, I just read a research study from Market Research that suggests that 75% of those facing infertility never actually can pursue reproductive technologies because of the cost disparity. Thank you.
Well, I'd like to thank our panel and all of our participants. Thank you.